So, yes, so a very warm welcome to all of you who are looking at our presentation live on Facebook, and also to all the people that will look at the presentations later. It is my greatest pleasure to introduce you to ELPA Symposium this year that is focused on fatty liver disease in children and its impact that it has on children. I was just looking through the agenda of previous meetings, and I do need to say that meeting to meeting, the quality of the speakers and quality of the topics that we handle is increasing. And this is because of two persons from ELPA family who are working very tirelessly to bring us the best of the best. And I need to say thank you just at the beginning. So Dr. Teresa Casanovas, who is the leader also of this scientific committee at European Liver Patient Association, and also Yanula Kula, who is the president of Cyprus Association and is part of ELPA. So they together brought an idea to have a ELPA symposium that would be focused on fatty liver and problems that children face, because we found out that it's best to start from the start, and what would be the best start than not with children. So today you are in for a 2-hour meeting of a very high level speakers, and we will tackle this topic from every possible corner. So we will look at it from the political view, we will look at it from the professional medical view, we will look at it from the patient view, and not only from one patient, but from several different patient representatives' view. So just enjoy the program, and if you have any questions, please write them on the Facebook under the presentation, or send it to ELPA's office, and we will try in the meeting to also answer your questions. But without further ado, I will give now the floor to the two chairs of the meeting, and very welcome again.
Good morning to everybody. Thank you for your good words, Marco. It's a great honor to present today in our meeting the political point of view, and Mr. Dimitris Papadakis, he will share with us his opinion. Mr. Dimitris Papadakis is a member of the European Parliament, a group of the Progressive Alliance of Socialists and Democrats, and member of Committee of the Environment, Public Health and Food Safety. The floor is yours, Mr. Papadakis.
Θα πρέπει να αναλάβουμε όλοι τις ευθύνες μας. Να έχουμε υγιή παιδιά για να είναι υγιείς ως ενήλικες. Θα πρέπει να προστατέψουμε τα παιδιά μας παρέχοντας τους την κατάλληλη διατροφή, αποφεύγοντας τροφές οι οποίες προκαλούν λίπος γύρω από το ύπαρκτο τους. Θα πρέπει να μάθουμε τα παιδιά μας να ασκούνται, να αθλούνται, για να μπορέσουν να έχουν έναν ευίωνο μέλλον ως υγιείς πολίτες και όχι ως πολίτες με διάφορα και πολλαπλά προβλήματα υγείας. Ας κάνουμε όλοι το καθήκον μας, να προστατέψουμε τη δημόσια υγεία. Εγώ νομίζω ότι μπορούμε, ας το εφαρμόσουμε.
Thank you. Now our speaker will be Mr. Marco Greco, who is the president of the European Patients Forum from Belgium, and his title is The Importance of Involving Young Patients in Patients Organizations at All Levels, the EPF case. Thank you.
Thank you for this invitation. It's always a pleasure to be here with such a panel of experts, and to have the possibility of attending such an interesting meeting, because I will never stop tell how important it is to work on young patients, how essential it is to engage with them and to keep on engaging them and the families for what is important in long term for their health. Very often, particularly patients with this disease, experience also a stigma that is even worse when you are a teenager or when you are a kid. So I've heard from the previous speaker a very important underlining of the importance of education in these. It's for sure essential to develop tools that will enable our children to be more aware, but also to engage more with the families in order to work on prevention and better handling of the situation. Those of you that knows me a bit better, they know that I'm coming originally from another disease area, from the IBD area, so gastrointestinal issue, although I have myself fatty liver, so I'm particularly sympathetic with your work and with the importance of what you're doing. In my experience working with for 25 years with Crohn's disease patients, we have seen, and also within APF, we have seen how important it is not only to develop strategies, tools, instruments for young patients and their family, but also to engage directly with them, working directly with them, because the results is more efficient, is more effective. And also, not to mention the fact that in long term, you are also creating a new generation of patient advocates. I am particularly next to this kind of argument for the very simple reason that my, let's say, experience as patient advocate has started as youth representative of Crohn's disease patients many years ago, when my hairs were not white. And I learned a lot. I've become a better patient, better informed patient. I've developed more skills that have allowed me to better cope with my condition, but also I was enabled to help other people and to work and to advocate for other people. In this sense, APF, and I'm asking if it is possible to have my presentation on, because I cannot see it at the moment, I don't know why. Okay, it's there, sorry, next slide. I'm taking today the experience of APF in supporting our members in developing activities for young members, considering that parents' views are generally sought as proxies for their children, but there is still an essential need to listen to children and young people themselves. Adolescents in particular and young adults are in a very vulnerable life stage, potentially affecting their health behavior and mental health in very long term. Yet they are often thought of as a part of either the pediatric or the adult patients group and not as a separate group with special needs. Only young patients can give, in some cases, authentic advice on how to engage or communicate to other young patients successfully, because they bring a unique, often creative, out-of-the-box approach. This is what we have learned in these 20 years working with young patients. Creating an interaction with them allow us to better communicate with other patients in the same age range. It's essential to create a strong cooperation, particularly with the medical community, in delivering material, delivering instruments, because these instruments need to speak in a certain language, in a certain way, but they have to be scientifically precise. It's essential that young patients, particularly in this era in which they can get any kind of information they want easily on internet, they can find reliable information written in a way that is fully understandable for them. It's the only way for not being patronizing, but to allow them also to develop their own conscious strategy about how to cope with the disease. I'm talking here clearly about mainly about teenagers in the second when they are becoming young patients. But in any case, we suggest and we offer also instruments for opening a dialogue also with children and their families. It's clear that the approach is different, but still it's important also to have the patients himself or herself directly engaged with what's happening and directly understanding, because it's not us telling this, but it's literature that are suggesting this will make the patients more comfortable in and more let's say adherent to the therapeutic indication, and will make the entire work more efficient, the entire work of the people around the patients more efficient. Next one. What we do in APF is having a full-time APF youth group board made by patients representatives that are young, so basically from 16 to 25, 28. One of them is also a full representative in the APF board. This is in line also with what is happening with many EU authorities. I'm mentioning here the wonderful experience of the EU Health Parliament that is made by youngsters. It's a fantastic pot that is boiling with great ideas. And also the fact that even EMA, so the European Medicine Agency, is keep on engaging more and more with the young patients directly. We are in APF executing a youth strategy that has been developed by the youngsters themselves in order to better engage with these particular age range. This because we believe that bringing the young patient's perspective to various APF activities such as webinars, workshops, and so on is a plus. It's important to better communicate the specific needs of young patients, but also to develop something that at the end of the day will reach them in a positive way. On the right side of the slides, you see some of our youth representatives, and I can tell you that these, I will be very direct, the money that APF has put in this project are one of the budget line that is paying back in a fantastic way more than others. Next one, that I think it's the last one. Okay, the actual APF group is currently made of 9 members coming from all over Europe, representing different disease areas. The group was established in APF officially in 2011, and since then has been working on addressing the expectation of young patients and communicating them to APF. We needed this experience, but as I say, I am particularly sensitive about that because I've been a patient's representative myself, creating the FK Youth Group many years ago. So I can tell you how valuable this experience it is. This doesn't mean that this group needs more resources than others. That doesn't mean that we need to forget other age group. It's simply the experience says that when you're working with the young patients, you need a different approach. The new generations, they develop a completely new language that is different from the one that we were using when I was at that age. They have different instruments today, and it is important, considering the long term, also the long-term social cost of chronic diseases, to approach them as early as possible in order to develop a more efficient way. It's not, to conclude, it's not a way of preferring this group to others. It's not a way of giving more money to this group than others. It's simply a way to be more efficient, to put their resources that are well used, better used, and more efficient at the end of the day. I think this is all I was supposed to say today. I just want to close so far with a remark. Once again, thanks for your work. And thanks for having invited me and to keep me in this loop. It's for me a pleasure to be part of this family, and considering what Marco said, that at the beginning, that the panel is improving and improving, the fact that you keep on inviting me, it's for me an honor, and it means that I'm improving as well over the months, and so it's positive. Thank you. I have a very peculiar situation in my life in these days, so I will have to leave soon, but I'm looking forward to keep on this cooperation, and you can count on APF for developing activities for young patients, and overall for keep on working together for better future of patients in Europe. Thank you.
Thank you, Mr. Marco Greco, for your presentation. Now I introduce Professor Manuel Romero Gomez. He's a pathologist, and he is one of the top-level researchers and clinicians on the topic of NAFLD and MASH, and also the changing the name of the disease. Now his presentation is titled NAFLD or MAFLD, Pros and Cons of Changing the Name. Please, Professor Romero.
Thank you very much, Teresa. It's a great pleasure for me to participate in this very, very interesting symposium. I think ELPA is working very well. I have the opportunity to share with Vicky and many other participants last week on the NAFLD Summit. And it's very important to put together all the people involved in this type of action. And congratulations for moving forward. Today, I would like to analyze the pros and cons of changing the name. For sure, Jacinto Benavente, the Nobel Prize in 1922, 100 years ago, said that we need to change the name of the things to change the things, not just to change the name. And this is the main aim for today. How can we denominate the diseases? It's changing and evolving, and several times very difficult to define exactly what is the final name that's accept everybody. For sure, it's very common that several names could survive over the time. Like, for example, primary biliary cirrhosis was very a term that promotes anxiety, that because the majority of the female they did not were suffering from cirrhosis, appeared the term primary biliary cholangitis, but for sure in patients with cirrhosis we prefer the first. That means we don't need to fight one versus other, we need to look for the best. It's very important that Jacob George from Australia start working with a large consortium of people involved in this task. Could we change the name of non-alcoholic fatty liver disease to any other? After an intense debate, the metabolic associated fatty liver disease appear. I think it could be a quite interesting name, but curiously, the F of fatty in the recent times, in the recent month, perhaps not months but years, we need to think that it could be fatty, but also it could be fibrosis, because we know that the key point is happening in the liver is fibrosis progression that impact on the prognosis. For sure, we need to take into account when we are planning to change the name of a disease that we need to analyze what is happening with the current name, and using non-alcoholic fatty liver disease is a little confusing because in Spanish it's not very easy to speech, and people did not catch exactly what it means. And this is not a minor problem, because it could impact on many aspects of how the society is looking at the disease. Here is a figure that in our editorial in which a non-alcoholic fatty liver disease could promote confusion, low awareness, because it's no alcoholic fatty, it seems not to be very important, could be a stigma, because some people, they take just the non-alcoholic part, that means I could be an alcoholic, I don't know if, and it could be a stigma for them. And for sure, it's a negative number. This for future could impact in both in the sympathize and also in the poor quality of life, because we are not doing our best to manage this disease. I think we need to keep in mind 4 main factors. Non-alcoholic is a negative name, promote confusion and stigmatization. For example, as we are discussing today in the pediatric field in children, it not makes sense that you are explaining the parents that this age 9, 10 years old boy is not alcoholic, for sure. We know that. And this was one of the first elements we include in mind to promote the change. But also talking about alcohol, even in the adults patient, is not very easy. It's very difficult to know exactly the amount of alcohol. Could be a small amount, could be safe. Just you need to drink more than a quantity. It's very controversial in clinical practice, and for sure in the society. And even in the recent development of the pathophysiology, we detect that in the microbiota we can find bacteria like Klebsiella pneumoniae high alcohol production that could produce endogenous alcohol and facilitate the pathophysiology of the disease. That means that we are talking about non-alcoholic, but our bacteria, they are producing alcohol. For sure, non-alcoholic seems to be removed. For insulin resistance and lipid metabolisms are 2 metabolic pathway, 2 physiopathological pathway, and for sure the term metabolic should be included. Fat is consubstantial with the denomination. Fat is present at the beginning. We could be controversial, discuss what is the relevance, the clinical relevance of the presence of fat in the liver in the late stage. Perhaps keeping fat in the liver could be safer, and it's convenient for us, but for sure fat belong to the term. And finally, the majority of the problem, they are happening in the liver, and liver or hepatic should be included in the term. This is the main reason by which we promote to work with the term metabolic associated or metabolic dysfunction associated fatty liver disease. For we have a very heterogeneous disease with many factors, many phenotypes according to obesity, according to diabetes. It's a very dynamic disease. Today is steatosis. In a couple of years, steatohepatitis could develop fibrosis, regress, progress. It's a catalytic disease in which all the risk factors participate in a vicious cycle to promote the disease and influenced by several multi-axis. As reported in several papers by Eduardo Villar Gomez and Mohammed Slam and Javier Ampuero, these 3 young hepatologists working very hard on this field that I have the fortune to share with them many times in our life. When we were discussing about that, we tried to have a consensus in Spain, and using the Spanish registry, the EPAMED, we start debating what is the correct name of the disease. And at the end of the day, we decide that metabolic associated fatty liver disease after Adelphi could be convenient. In Spanish is steatosis hepatica metabolica. It's much easier to pronounce in comparison with the previous names in Spain. Finally, the proposal by Mohammed Slang and Jacob George that every patient with fat in the liver, if you demonstrate the patient has fat in the liver by ultrasonography, CAP, or liver biopsy, magnetic resonance, in a patient with fat, if we demonstrate that he is suffering from obesity or for diabetes, the patient is suffering from NAFLD. Just in lean patient, we need a couple of metabolic disturbance to diagnose NAFLD. But I think if we are taking care of a patient with 10 years old with diabetes, we cannot think the etiology of the liver disease could be related to any other any other pathological problem beyond this diabetes. Metabolic associated fatty liver disease is a correct name. I think will growing space on the literature, for example, in the pediatric field, is I'm sure is 100% the name that we are using. In the hepatologists, perhaps some groups could prefer to keep both. I agree, we need to collaborate, we need to share the space, we don't need to fight just one, but for sure, for these people that we feel more comfortable when talking with a patient, with a payer or stakeholder, that we have a positive definition, a term that avoid including alcohol due to all the controversial I commented before, including hepatic, including metabolic, and including fat or steatosis is a correct number that could allow us to improve the impact and the awareness on the society of this big disease. This is a major health problem that requires the effort of all of us around this type of action like this that the ELPA is promoting today. Thank you very much for your attention, and we are keeping on this fantastic round table. Thank you, Dr. Casanovas.
Thank you. Thank you very much, Professor Romero. I think it's very clear the position and the new name, and we will follow. Fatty liver disease requires coordinated response. And now we have Ms. Nikki Alkistis-Potiu. She's clinical dietitian and nutritionist in Cyprus. And her title is The Importance of Healthy Eating, the Sooner the Better. Please, Mrs. Nikki.
Good morning, ladies and gentlemen. I'll just share my presentation. Thank you for inviting me to this event, and I am delighted to take part. Today I will be talking about the importance of healthy eating and physical activity as well in the prevention of...
Sorry to interrupt you, we cannot see your slide. So either we will try again or I can share for you if you prefer.
I'll try again.
Thanks, sorry to interrupt you. I can share, no problem.
I've made some changes to the presentation.
Okay. So I can guide you in sharing.
Yes,
that's
please.
better. Okay, so you have the bottom share screen. You just click and you have the overview of the file you have open. So my suggestion is opening the presentation, tab it down, so put it down. And then you will find the presentation with the title in this overview, and just click on it and click share the button. I don't know if I was.
Yep. Let me just. Is it working now?
And no, I cannot see it.
Let me. Bear with me a minute, it will be sorted out. Yep.
Yes, yes. Perfect.
Apologies for the delay.
No problem. We can see it perfectly. Thanks.
Okay. Like I said before, I'm going to be talking about the physical activity and healthy eating as well, and how we can prevent obesity and NAFLD in children. So we are going to shift the focus on nutrition and dietary habits and physical activity levels and how they're linked to NAFLD and obesity. We're going to touch on the multidimensional contributing factors and the strategies that have been put in place so far to tackle the problem from a really young age as well, and as well as what areas we need to improve on and improve our strategies. The rise in overweight and obesity in children is distressing, given the strong link between excess adiposity and the detrimental health outcomes later in life. Research shows that compared to normal weight, children, those who are overweight or obese, are more likely to go on to become obese adults. And so they have an increased risk of developing associated health issues such as NAFLD. What is more concerning is that 1 in 3 children in the EU aged between 6 to 9 is overweight or obese. And since poor diet and physical activity are important determinants of fat buildup in children, for children, a healthy diet and physical activity and an active lifestyle can also contribute to their healthy growth and development. Changes in the average European's lifestyle are thought to be responsible for the increases in overweight and obesity seen across all age groups. This issue is complex and there are several factors contributing that we need to be addressed if we want to see a decline in this upward trend. One factor is our eating patterns, the types of food we eat, the portion sizes, and children now consume more fast foods and spend less time eating homemade meals. Also, prepared and processed foods are more accessible than ever before and in larger portion sizes. Often fast food and ready meals are calorie dense, low in nutrients, high in saturated fats as well, sugar, salt, and trans fats. There has also been a substantial increase in sugary drinks among children, and they're really nutritionally empty and calorie dense. We also eat less like the Mediterranean way, like the Mediterranean diet, which is characterized by high intake of olive oil, nuts, fruits, vegetables, and fish, and low intake of red and processed meats. The Mediterranean diet can be beneficial in the prevention of NAFLD in children. So screen time and decreased physical activity. Watching television and spending time on computers are becoming more popular among children now. This is leading to passive overconsumption, which means children are less likely to be aware of the portion sizes that they eat when they're watching TV, and they are playing games. Also, food and beverage advertisements when the children are playing video games and watching TV have also been shown to increase the consumption of high-calorie foods. More screen time also means more sedentary behaviors, which detract from more active leisure time, such as sport or playing, which used to be more popular. Among other factors, the physical environment is thought to play a key role in the activity patterns, like the facilities that the children have to go and play outside and be physically active in. This chart on the right compares the activity levels between boys and girls across member states of the EU. It's concerning that in 2018, 1 in 4 11-year-olds and only about 1 in 7 15-year-olds reported having adequate exercise. So another factor that plays its role is the socioeconomic status and food insecurity. Overweight and obesity in children in Europe is associated with lower parental socioeconomic status and lower socioeconomic status where NAFLD is prevalent. Physical activity, food insecurity, and obesity are associated. Research indicates that individuals who are food insecure have 20 to 40% higher risk of becoming obese compared to those with food security. At present, however, we need more data to investigate this in the EU. So far, research suggests that higher obesity rates in deprived areas are partly attributed to the fact that the households are less likely to make healthy choices when food shopping, and less healthy options are cheaper compared to like fruits and vegetables, which are usually more expensive. These factors contribute to increasing the disparity of health inequalities among children as well. Another factor is the nutrition during pregnancy and early life stages. Nutrition during, appropriate nutrition during pregnancy and lactation is essential for the future well-being, both for the mother and for the child. A mother's preconception weight and the weight gain during the pregnancy are two of the most important prenatal determinants of childhood obesity. Also, breastfeeding is considered the best option for newborns and infants, providing significant health advantages. Research shows that children who are breastfed appear to have a reduced risk of obesity later in life. In the EU region, we have the lowest rates of exclusive breastfeeding at 25% at the age of 6 months, which we need to work towards improving. All right, now prevention. We have presented the multifactorial problem, but what we can do to prevent it. In the next few slides, we're going to briefly see how we can tackle some of the areas of concern. Non-alcoholic fatty liver is prevalence in Europe is preventable, which we can prevent by starting from an early age, implementing change both at the national and EU level, as well as a population and as individuals as well is essential in this case. Let's briefly talk about the impact of COVID-19. Children have been greatly affected and experienced vast changes in their lifestyles. Although there are limited studies and statistics for now, the EU is expecting that dietary habits and physical activity levels are negatively affected by COVID and consequently negatively impact obesity levels as well. School closures, lockdowns, social distancing, and fear even can impact access to school meals, physical activity times for children, which also widens the inequalities in disadvantaged groups. So far, from the limited statistics we have, numbers are not looking very promising for our children's health, and so childhood obesity prevention strategies should therefore remain a priority during the pandemic as well. So the solutions that we have on a nutritional level is a multidisciplinary approach, which is essential. We need to keep educating healthcare professionals such as school nurses, dietitians, nutritionists, physicians, and so on their responsibility to provide counseling and support the public on healthy eating. For example, things like reading and interpreting food labels, food portion sizes, and making mindful and informed food choices. We also need to keep educating healthcare professionals involved in prenatal care, on diet, to educate women and pregnant women on diet and physical activity. And also hospitals need to ensure that the new mothers and their families receive proper information and support on breastfeeding and complementary foods as well. So the solutions on a national and EU level, we need to, not all the solutions can be applicable to at an EU level. Some need to be tailored to each member state. We won't be able to go into individual country strategies, but we're going to touch on major strategies here. Since children spend much time of their day at school, it is critical to involve schools in tackling overweight and obesity in children. It is vital that meals provided in schools are healthy, that the nutritional quality of the foods in schools is improved, and that the healthy option is always the easier option for the children to choose. Especially with the impact of COVID-19 and the increasing rates of obesity and NAFLD, it is critical that funding should continue or increase for school interventions such as healthy eating days, healthy eating stands, talks, and sports days. Mass media campaigns now can be encouraged, and the food industry needs to take initiatives in areas such as food marketing, promotion of healthy eating and exercise, and reducing misinformation. Adequate funding for research plays a very important role here. We do have research in obesity, but we have a lot to improve on in the EU. So we need to work together to improve collective data collection. Last but not least, we must put special focus on providing vulnerable children in socially disadvantaged communities with healthy food options and safe areas to facilitate physical activity, especially under these uncertain times. Other states have introduced food banks powered by volunteers to tackle food insecurity in deprived areas. Other actions all states should take is provide community talks, provide safe facilities such as gyms and parks in communities. This shows the significant increase in life years of the population when some of the previous suggestions were applied so far. And lastly, overall, the key areas we should focus and improve more to empower our children and our future adult population are to support a healthy start at early life stages, to promote healthy eating at schools, to restrict marketing and advertising to children when it has to be, and encourage physical activity. Increase the research and academia, and make the healthy option the easy option, both for parents and for the children. list of the references, and thank you, everyone.
Thank you, Ms. Nikki Alkistis-Potiou, for your clarifying presentation. Thank you very much. Our next speaker is Professor Volkander Mirham Yumuk. He is Professor of Medicine, Endocrinology, Metabolism, and Diabetes in the University in Istanbul, Turkey, and he is also the President-elect of the EASO. His presentation is entitled Liver Matters in Obesity Clinics. Please, Professor.
Why don't you show my slides?
Yeah, I can share.
Yeah.
Ah, no, okay.
Thank you very much, Teresa, for the kind introduction. I'm very pleased to be here addressing to liver patients. As you have heard, I'm an adult clinical endocrinologist working in Istanbul, and I'm running an obesity center, which is a collaborating center for obesity management. That is a unique initiative of the European Association for the Study of Obesity. Its mission is to standardize obesity care and promote obesity research. As you can see here in this picture, we have a multidisciplinary team. This is the core team that we have. And we have a clinical psychologist, a bariatric surgeon, an endocrinologist, an exercise specialist, and a dietitian. And we also have other disciplines when referral time comes. Next slide, please. We function according to the European guidelines, EASO European guidelines for obesity management in adults. And it is briefly lifestyle modification, which is balanced hypocaloric diet, physical activity in the form of exercise with certain intensity, duration, and frequency. Then again, another important aspect is behavior change. So this enables proper nutrition and proper exercising. And as indicated, we use pharmacotherapy and bariatric surgery. Next slide, please. Next slide. So on this slide, you see that obesity has multiple complications. First of all, obesity is a chronic relapsing disease, and it has complications that are also chronic. And one of these complications is liver-related, and that is non-alcoholic fatty liver disease. And from now on, I will be referring to it as NAFLD. Next slide. And we also, in the obesity clinic, we know that the natural history of NAFLD is that there is prognosis from, there is progression from steatosis to NASH, NASH to fibrosis, and from there to cirrhosis, and eventually would be hepatocellular carcinoma. So with this information, I believe that liver matters in obesity clinics. Next slide. A brief summary giving some numbers in adults. NAFLD is considered the most common cause of chronic liver disease globally, affecting 25% of the adults. and 3% of this is non-alcoholic steatohepatitis. From now on, I will be referring to as NASH. In a meta-analysis, the prevalence of NAFLD in subjects with type 2 diabetes was 55.5%. Of NASH, it was 37.3%. And NAFLD was present in 51% of people living with obesity. 15 to 20% of NASH can progress to cirrhosis, 5 to 10 to end-stage liver disease. And eventually, NASH is the second most common indication for liver transplantation in the year 2019 in the States. And the trends in Europe are not that different. Next slide. Again, another reason that liver should matter in obesity clinics. According to this study, where there is a cohort with type 2 diabetes and normal plasma transaminases. And when you compare the NAFLD prevalence and check the BMI of these patients, the NAFLD prevalence in the group with a BMI between 35 and 39.9 compared to non-obese group and the class 1 obesity group, it has doubled. And when you look at the last bar, when BMI is, the body mass index is equal to or above 40, it's almost all of those patients are going to have NAFLD. Next slide. For us, the mortality rate is very significant. And in this slide, according to this analysis, the mortality rate, when you compare the isolated steatosis, which is NAFL, with those who don't have NAFLD, what you see is the rate of cardiovascular mortality has almost doubled. Next slide. I mean, next, yeah, another one for the arrow, yes. And when you compare the NAFL, which is isolated steatosis, with NASH, then what you see is that the mortality rate, liver-related mortality rate has increased, cardiovascular mortality rate has become stable or less. So the last two slides that I showed you show us that liver matters for obesity clinics, and obesity should matter for liver clinics. Next slide. Another important slide that I would like to show you is demonstrating that weight loss is associated with improvement in NAFLD. So this is a very important piece of information. So the good news is the weight loss on the left side. So at least 3% weight loss, 3% of the initial weight, leads to improvement in steatosis in at least 35% of the patients. And it can go up to 100% in this study, depending on the degree of weight loss. So when there is at least 5% of weight loss, ballooning and inflammation improve. At least 7% NASH resolution occurs. And when the weight loss is more than 10% of initial weight, there would be fibrosis regression in 45% of patients, at least one stage below. It goes to one stage below when it regresses. But the bad news is on the right side. What is the bad news? Well, the bad news is we can attain weight loss, but it's difficult to maintain it. So maintenance of weight loss and prevention of weight regain is a significant issue in our patients. And that's why there is a collaborating obesity center with a multidisciplinary team. And the follow-up is essential, both in obesity clinics and liver clinics. So, and the follow-up, the management with the follow-up should be lifelong. Next slide. I also have some information regarding children. Although I'm not seeing this population, they may come to us during the transition period, and then on we may follow them in as young adults and on. It is again considered the leading cause of chronic liver disease in children, NAFLD. Obesity, especially central obesity, which is related with insulin resistance, are major risk factors. 7.6% of children in the general pediatric population have NAFLD, and 34% of children with obesity have NAFLD. So obesity is also crucial in children as far as NAFLD is concerned. So the last comment there is concerning me and my team. Overweight and obesity at childhood ages is associated with adult NAFLD, end-stage liver disease, and liver cancer. So again, I believe that liver matters in obesity clinics. And I added to it the second statement, which is obesity should matter in liver clinics. Next slide. This is my last slide, wrapping up the context and the concept that we need to have an integrated approach to obesity, diabetes, and NAFLD, both in adults and children and adolescents. So multidisciplinary approach with a team. Cardiovascular risk reduction is essential, mostly concerning adults. And therefore, we should be managing dyslipidemia, hypertension, and smoking. We screen for complications of obesity in obesity clinics. So that's how we diagnose NAFLD. We need to choose anti-diabetic medications that may reduce weight or may be weight neutral. Lifestyle interventions, lifestyle modification is a must. And we should be adding obesity pharmacotherapy, and as indicated, bariatric surgery when appropriate. In patients with advanced liver disease, we choose and dose the drugs for presence of diabetes or weight management appropriately. So this also shows us that we should be collaborating with liver clinics as obesity clinics. And my message today would be liver matters in obesity clinics, and obesity should matter in liver clinics. We should have a integrated approach. And in our team, in addition to the 5 healthcare providers, the patient herself or himself is also the most important part of our management team. Next slide. Thank you very much.
Thank you, Professor Volkan Yumuk, and thank you very much for your clear messages.
Yanula, I would kindly ask you to unmute yourself. Thank you.
Yes, it's a great pleasure to welcome to our symposium Mrs. Vicky Mooney. Mrs. Vicky Mooney is a patient advocate, public speaker, and the executive director of the EASO, originally from Ireland, now living in Lanzarote. Yes, I read it well. Vicky used her voices to help address the stigma, the discrimination against people living with obesity. Welcome, Mrs. Mooney.
Thank you kindly, and thank you for having me here today. It's a pleasure to be with you all. I don't have a presentation to share, so I'm not going to be sharing my screen, but I'm going to be just sharing, I suppose, some thoughts around the obesity and the liver community, really. I suppose, first and foremost, I'm a patient myself with obesity and a number of chronic diseases. And I have had obesity all of my life, unfortunately. I think probably some of the challenges that we have when we talk about fatty liver disease and we talk about obesity is the stigma that's involved. I was super grateful earlier for Professor Romero when he discussed metabolically associated fatty liver disease and taking away that stigma of non-alcoholic, and his presentation sharing how challenging it is for children in particular and confusing it is, was just fantastic. And I think part of the challenge that we have is that in society, we are not aligned with the science behind fatty liver disease and obesity. We still have that old lifestyle intervention, that eat less, move more attitude. And yes, we all have a tremendous responsibility to our health. We have a responsibility to our children's health. We have a responsibility to ensuring that they are getting the best nutrition and the best physical activity they can have. However, it's not just eat less and move more. And I think we're all moving in the direction of understanding that obesity is far more than just eat less and move more. We know it can be genetic up to 70%. We know it can be socioeconomical. We can know it's environmental. We know from Vulcan's fantastic presentation that we need a multidisciplinary approach. And I think when we look at children, this is really key in managing their obesity and ensuring that they don't get to that stage of fatty liver disease. And I know Emer Fitzpatrick's going to come on and give a fantastic presentation shortly actually on children and that as well. But lifestyle intervention it's not enough. We've had enough of the conversation. We need to change the narrative. We need to align with the science. I think one of the best practices I've seen actually when we talk about lifestyle intervention is in Portugal. Portugal for the last 10 years have been running an educational program in schools called Fruit Heroes. And in the last 10 years, 500,000 children in Portugal have actually improved their eating through this program. Mario Silva, who is one of our patient council representatives, has been working and leading the charge there with this. And yes, we need intervention like that. We need that education. We need children to understand, but we also need to share the narrative that obesity is a chronic disease, as well been shared. And without that conversation actually changing, that stigma is going to linger. And unfortunately, the youth of today won't be able to move away from it. I think probably one of the challenges I look at myself, I'm really happy I'm not a teenager in this day and age where we have Instagram and social media, where it's so heavily focused on image and how a person looks. And when we talk about obesity and fatty liver disease, we're talking about something that is, even fatty liver disease, if you have obesity, it's visual. You can see somebody has obesity. For a child, where the focus is, the emphasis is on the vision of their body shape, their body size, you know, how curvy they are, you know, how straight their body is, how fast they can run, how that is an extremely challenging experience for any child. I look at my own children and I see their challenges, and 2 of my 3 children have obesity. So I think one of the things that we can do as communities working together is broaden the conversation beyond just lifestyle without losing the responsibility to our health. And I take that as a patient with obesity and say, I have a responsibility to what I put in my body and how I move my body. But let's broaden that conversation. I think if we can do that, and as Volkan ended beautifully on, have an integrated approach, I think we will actually move in the right direction. So thank you for your time, and I will pass back now. Thank you very much.
Thank you very much. Teresa, you will go on, I think.
Thank you. Thank you very much. Our next speaker is Dr. Emma Fitzpatrick. Dr. Emma Fitzpatrick is pediatrician and hepatologist at Crumlin Hospital in Dublin, Ireland, and member of the EPCOM in the European Pediatrics Gastroenterology, Hepatology, Nutrition Association. She will present fatty liver disease in children. Thank you.
Good morning. First of all, it's an absolute honor to be speaking to you and a pleasure to be following a fellow countrywoman. So thank you very much, Vicky, for that talk. So I'm a pediatric hepatologist, and my big interest is in fatty liver disease in childhood. And I work now in Dublin, but I still run the fatty liver disease clinic in Kings. And you can imagine that's been a bit of a challenge over COVID, but we've managed. So I'm just moving my slides. So, you know, we know well that NAFLD, which is essentially the liver manifestation of the metabolic syndrome, is really increasing in prevalence, and it's increasing in prevalence particularly where obesity is more prevalent. But there's more to it in that, particularly in children. And I want to talk a little bit about that and about my personal approach or the approach of Kings and Dublin to children with NAFLD. So we all know, you know, the definition of NAFLD is fatty liver with or without inflammation and scarring. So essentially, you know, in kids, certainly on biopsies, I see less inflammation, but I see a lot of steatosis, a lot of fat, and a lot of scarring. But the crucial point here, I think, and this is obviously the generic definition of NAFLD, but it's in the absence of any other underlying condition. And that's a really important point when it comes to pediatrics. Because although, and I really welcome changing the name of NAFLD to something else, when we are thinking about conditions in children, we have to consider in the differential diagnosis, the inborn errors of metabolism. So, you know, even broadening that out to things like Wilson's disease. So in terms of screening children that come into our clinic, we never assume this is NAFLD before doing a full screen, including incorporating things like, you know, rare diseases like urea cycle defects. So that's why we've held off a bit on changing the name to MAFLD, because metabolic to us means slightly different to the metabolic syndrome. But as you will know, I mean, NAFLD has been around a number of decades now, and the definition or the description in children followed very quickly on from the description in adults in 1980. And we know from Volkan's superb talk that it's the leading cause of chronic liver disease in children. It's the most common reason that you may be referred to me. You know, there've been a number of studies, and Valerio Nobili, God rest his soul, who died very suddenly a couple of years ago now, has done a huge amount of work in this area. Probably the most accurate study in children is actually an autopsy study of children who died of unrelated conditions. And in those, they found that 10% actually had fatty liver, unbeknownst to themselves. Up to 80% of children who are obese may have fatty liver disease. And again, that's quite related to where you are in the world, as I'll talk about a little bit later. And it is a leading indication for liver transplantation in adults, not so much in children, but we are essentially handing over these children with, in some cases, reasonably rapidly progressive scarring to our adult colleagues. And, you know, this is bound up in this vicious cycle of childhood obesity. So whatever starts this off, and undoubtedly genetic susceptibility, as I'm going to talk about in a little bit, you know, is one of the predisposing factors. But once you're in that cycle, it is really, really hard to break. But the advantage, I think, in pediatrics is we can break it. So as I said, there is more to NAFLD in my mind than just fast food. There's genetic factors, and now, you know, genome-wide studies are telling us more and more about what's relevant. As Nikki was telling us, intrauterine environment and early infancy exposures, and including breastfeeding, are really important and a really important consideration for public health. I also believe, and this is a bit of hypothesis here, but that the liver, the pediatric liver, is vulnerable in a different way to various toxins. And we know that from the different zonality and how the liver matures over time. And also, you know, there's obviously rapid growth in childhood. So you see that prepubertal phase where, you know, probably insulin levels are high, and you've got a rapid period of growth. And that's where we see the first kind of peak of presentation, particularly in boys with NAFLD. But I guess the point about it is that when we do liver biopsies, and we do liver biopsies in some children who we think have either really significant fibrosis or that we need to rule out something else. And we find scarring in 50, you know, significant scarring. So if you think about it's F0, which is no scarring, to F4, which is cirrhosis, we find an F2, F3 in about 50%. And this is really relevant to children over the 60 to 70 years, you know, plus hopefully 80, 90 years that they will live. Because we know that in some we can't pick them out, but scarring will progress. And I liken it like a splinter. So if you think of fat as a splinter in your liver, for some people, a splinter doesn't cause any inflammation or scarring, but for others, it goes on. And unless you remove that splinter, you know, you're destined to have scarring, and in some cases, really bad keloid scar. I'm just mentioning here again the importance of ruling out other causes. So as I said, when a child presents to me with a suspicion of fatty liver, I do a number of other routine investigations to rule out any other cause of a disease of the inborn errors of metabolism. So what, you know, predisposing factors we've talked a lot about, you know, lifestyle, but, you know, that there are other considerations. So we know that it's not, you know, NAFLD is not directly related to your absolute BMI, right? So you can be overweight and still have good going NAFLD. You know, there are certainly ethnicity relationships, particularly Hispanic, then Asian, Caucasian, Africans seem to be most protected, even though their incidence of type 2 diabetes is higher. And certain dietary foods have been implicated. But to be honest with you, and you know, we've done our own studies, and you know, there's been many studies done, and it's not just one thing, and it's not just one thing, I think, for any individual child. So children will often present with no or non-specific symptoms. So they'll be incidentally found to have a high ALT, or they'll have an ultrasound for tummy pain, and they'll be found to have a fatty or steatotic liver on ultrasound. This will often be in the context of other family members with aspects of the metabolic syndrome. The majority that do come to clinic are overweight or obese, but there are a number of normal weight. Now, the normal weight NAFLD does tend to be associated with kind of a central adiposity, if you like, that apple shape. And again, this is all genetically predisposed, I guess. I'll see a big liver or a big spleen in about 40% of the children I see. And you know, that non-specific tummy pain, I mean, I do think that may be because the liver is big and perhaps stretching the capsule a little bit. Liver blood tests may be entirely normal. Okay, so you know, we don't, particularly in children, I think, you know, the inflammatory component is probably not as florid, and more certainly it's a point in time measurement. Majority in my clinic have insulin resistance, and 17% of a pre-diabetes or diabetes phenotype that we tend to start metformin in. So you've seen this slide before. So this is about, that progression, and, the adult studies suggest that to progress one fibrosis stage, it probably takes about 8 years. And if you think about an 8-year-old presenting with F2 fibrosis, that's not a long time before they'll get to cirrhosis. So we know that the medical community is full of treatment trials for NAFLD, hot on the heels of type 2 diabetes, probiotics, fish oil, caffeine are some of the more alternative ones, but we've got a whole array of different drugs that are increasingly being trialed. And you can see, interventions for NAFLD, really huge number of clinical trials going on at the moment. And this is big business. Okay, so up to $40 billion in pharma in managing these conditions. But this, again, Volkan presented this slide, and I think this is really the most important one that we can, that we have to get into our heads. That actually, and these data are in adults, but there's a recent systematic review that just doesn't show it probably as obviously, but it essentially more than 10% of your body weight, you will pretty much resolve your NAFLD, but sustaining that is the key. I know 10%, as Volkan mentioned, get to that point, and the question is why. And it is easier said than done. And, you look at our own clinic experience where we looked at, a cohort going through just to try and audit what, how we were approaching this. And I have a super team. I've got a clinical nurse specialist and a dietitian. I don't have an exercise specialist, which I would love. And I've part of a psychologist who doesn't really have the time to spend in the clinic, is not dedicated to that, but would advise us. And we put in as much effort as we can in terms of education, lifestyle change and support. For, our dietitian is super, would call the families every 4 to 8 weeks, and really just to provide positive motivation and support. But our outcomes over 6 to 12 months weren't fantastic, although we did achieve something. I mean, at least we didn't see a BMI score going up. And I guess this is the key. What's missing? So what's missing to read? And I'm talking about a selected population where you have a diagnosis of NAFLD rather than a cohort of children who may be overweight or obese. So this, and we have the benefit of being able to provide a reasonably intensive program to those children. But the aspect that's missing here, and this is just one aspect, but it's one that I'm really interested in, and that is the psychosocial, the mental health aspect. So if you look at this study, and this is an adult study, and this compares patients with NAFLD to patients with primary biliary cirrhosis, which, as you know, is associated with dreadful itch and really quite a poor quality of life. And comparing the fatigue impact scale here of those with NAFLD, that reflected the same fatigue impact scale as those with PBC, which presumably that the fibrotic stage, the cirrhotic stage of these patients was quite different, in that the PBC group had probably more liver injury at that point in time. But this is that highlights that actually the NAFLD population, or those with NAFLD may have other issues that we really need to address, in addition to education and support. And we know from the research network in the States, which is a great job of collecting data from multiple centers, that children with NAFLD have worse total physical and psychosocial quality of life than controls. With fatigue in up to 70%, sadness in 50%, irritability, trouble concentrating, and sleeping, which I think is a really important point. Other issues such as bullying, obesity, and self-esteem, again, is real chicken and egg stuff. And I think we really do have a duty to try and separate this out and provide as much psychological support as we do education. And we know from adult studies that subclinical depression and anxiety have a really high prevalence in the population that present with NAFLD. And we have looked at our own cohort and found that, so this is using an ORCAD score, which really separates out, the top 7% of scores in terms of depression and anxiety, and this top 2%. And the prevalence here compared to 7% of a control is really huge. So what is different about this population? What are we missing here? Is it the NAFLD, which is predisposing them to depression and anxiety, or is it the starting point? And are things just getting out of control? And I guess the point here is that unless we address these issues, treatment effects are poorer. So we know that those with depression, and intensive lifestyle intervention was reasonably effective in those with kind of a stable depressive disorder, but in those with an unstable, it really didn't make any difference. And this is measuring an ALT and gamma-GT, which are obviously non-invasive measures, but I think in this particular population was a good proxy measure of disease control. So I guess to summarize my approach to NAFLD in children and young people, the first question I always ask is this NAFLD? And there's a long list of investigations that I think are really important. And yes, I select out, some for more investigations, the younger age, maybe lean NAFLD. The second question is that I want to ask, how bad is the liver disease at that point in time? We know that prognostication in terms of how a child will be in 10 or 20 years is impossible. But we use things like FibroScan, ultrasound scan in terms of measuring spleen size, not so much blood tests, to be honest, in trying to determine how bad the liver disease is at that point in time. And I guess that determines my follow-up and my the intensity of the intervention that we would try and give. And that, comes into how should we manage this patient? And that's why I think, and I'm looking forward, to hearing more about the multidisciplinary approach to this, and because I think it's absolutely essential. And then the final question that I think nobody really knows the answer to is, but how do we need to monitor and assess progression of liver disease? So just to, this is an overview of what we do. Usually we find a fatty liver on ultrasound, we do a workup. If there's red flags for something like Wilson's disease, we go down that pathway. We don't find another pathway, we look for other metabolic complications, and they may need their specific treatment like type 2 diabetes. We concentrate a lot on lifestyle management with quite intensive follow-up if we can. And then we provide surveillance with annual bloods and ultrasounds every year or so in addition to that. But we also try and screen for psychosocial comorbidities. And if we can, and certainly the NHS has got limited resources, but we're always fighting for psychology input, because I think that is a game changer for many children. So I leave you with that children are not necessarily small adults, but we can learn a lot from adult practice, I think. Thank you.
Thank you very much, Dr. Emma Fitzpatrick. Thank you for your ideas. We enjoy a lot your presentation. Our next speaker is Dr. Núria Fabrellas. She's a nurse. She is professor in the Faculty of Medicine and Health Science at the University of Barcelona, and also she's involved in research projects on the hepatology field. She will talk about the role of nurses in the multidisciplinary team in care of fatty liver. Please, Núria.
Thank you, Teresa, for the kind presentation. Good morning, everyone. I would like to thank the ELPA organization, especially Dr. Casanovas and Marco Korenjak, for inviting me in the ELPA Symposium. In my talk today, I'm going to discuss the role of nurses in the multidisciplinary team in care of fatty liver. A multidisciplinary team for treating disease gives an holistic treatment and centered patient care. The name of NAFLD, as Dr. Romero said, is under discussion. In this presentation, I'm going to use MAFLD instead of NAFLD, because in the definition of NAFLD appears the word the word alcohol, that, at least in my opinion, that means to perpetuate the stigmatization about liver disease. One moment. Okay. As you know, metabolic associated fatty liver disease, NAFLD, is defined by the presence of fat in more than 5% of hepatocytes. NAFLD consists of a spectrum of alteration in the liver that can range from simple fatty liver to mild moderate fibrosis and to advanced fibrosis or cirrhosis. In contrast with another chronic liver disease, NAFLD, the other chronic liver disease affect almost exclusively the liver, but in the NAFLD is a multi-systemic disease that besides the liver effect, other organs and systems are affected. NAFLD is the disease of the 21st century, and it's associated with the epidemics of obesity and diabetes mellitus. The global prevalence of NAFLD range from 6 to 35%, and in USA, approximately 30% of the population are affected by NAFLD. In Europe, the prevalence in the community population is 25%, but if people are obese, the percentage increased to 80%, and people with type 2 diabetics, the percentage is 55%.
Dear Nuria, sorry, can you share the screen completely for the presentation?
I have the screen.
You have a button down there to open, to be one slide big one, everybody to see it quite nice.
I don't know. Let me see.
Right?
Now?
Yes. Yeah.
Now it's okay?
No.
No. In my screen is a big. Now is, I don't know what happened. I don't know.
Bea, can you help her?
Unfortunately, Milan, we have only PDF of this presentation, so we cannot help Ms.
I can share exactly.
We can share the PDF. If not,
Dr. Fabregas, I can share the PDF.
Okay.
And I don't remember exactly which slides do you arrive, but we can find it together.
I think it's the third one.
Okay,
Yeah.
okay.
Count to the title.
I'm stopping you and I'm sharing. Okay.
Okay, thank you. Thank you
No
very
problem.
much. I appreciate.
No problem.
Thank you very much.
Thank you, Milan.
I'll put it full screen so it's much better.
Yeah.
And you told me the this one?
Yes.
Okay.
I start with that one. Okay. NAFLD is defined by the presence of steatosis with some components of the metabolic syndrome. These components are arterial hypertension, hyperglycemia, abdominal obesity, increased triglycerides, and low HDL. Around, the next slide, please. Okay. Around 80% of the patients with NAFLD also suffers metabolic disease such as obesity, diabetes, cardiovascular, and so that a multidisciplinary team is needed to discuss the best treatment options, because treating just one condition is not sufficient to improve patient conditions. Next, please. Okay. NAFLD in most cases is due to a combination of eating more calories than body needs and a sedentary lifestyles. So the eating well, a healthy diet and an active life are the cornerstones of the NAFLD treatment. One thing that we need to remember is that if the NAFLD is detected and managed early enough, it is possible to reduce the amount of fat in the liver, which may slow down or even stop the damage. Next, please. Okay. Because the multiple comorbidities, a multidisciplinary team is required. And the multidisciplinary team is a group of health professionals from different disciplines centered to the patient. The patient is in the middle. The patient is the most important person in that case. And all the professionals need to work for her or for his in order to get the best treatment. Most patients with NAFLD in the early stage could be managed exclusively in the primary care. And of course, with talking and coordinate with the hepatologist or cardiologist or the diabetologist or the dietitian, etc. The aim of the multidisciplinary team is ensuring that patients receive the optimum care and support. Next, please. This slide shows the actors in the multidisciplinary team. In the NAFLD, especially in the NAFLD, there are two kinds or two organizations that can follow or treat this patient. One is the primary health care, especially for the screening and in the early stage. And here they work all together, the GP with the nurse and a dietitian, and the follow-up the follow-up is done by the cardiologist, the pathologist from the hospital. One more. A multidisciplinary team requires mature leadership to create a democratic climate. And in my opinion, one of the best figures to lead a multidisciplinary team is the nurse. Next, please. A multidisciplinary team has some benefits. These benefits are the benefits is efficient and cost-effective approach, improve quality of care, the patient's quality of care, and promote self-management. Next, please. That's okay. In the previous slide, I forget to tell you that another member of the disciplinary team is the patient. Patient needs to be a part of this multidisciplinary team because one of the reasons, at least for the nurses, is to do education in order to teach the patient how to manage different symptoms or even how to recognize some risk. And well, this is why the patient need to be a part of the team, the multidisciplinary team. Finally, oh my goodness. No, this one is, I'm sorry, this is the last one. I would like to finish my presentation by emphasizing the important role of nurses, especially the advanced practice nurse in a multidisciplinary team. Because the nurses can help to develop self-care abilities, guide individuals in symptoms monitoring, provide follow-up in different settings and reminders, monitor progress towards patient improvement, and coordinate care between different members of the team. In my opinion, multidisciplinary teams need to be in all of the care in different disease. No matter if it's one disease or another disease, no matter if the patient is adult or a child. Thank you very much for your attention.
Thank you, Dr. Nuria Fabrellas, for your opinion and very clear presentation.
And now at this point, I would like to welcome Dr. Teresa Casanovas, who is a hepatologist and the president of the Spanish ELPA member association, ASCA. She's the coordinator and the leader of the ELPA scientific committee, and she focused her career on clinical care and research dedicated to liver diseases and liver patients. Your presentation, please, Dr.
Thank you. Thank you, Yanula. My presentation will be about stigmatization in children and teenagers with obesity. In the European region, the number of children with obesity is increasing, and this often causes psychological facts and consequences on body image, self-esteem, and stigma. Sorry, but I would like to have the complete screen, because if not, the last sentence is lost. Sorry.
Thank you, Teresa. We will try to stop sharing the screen and share it once again. Just,
thank you.
Give us a minute. Thank you.
Scusa, io lo vedo bene. Adesso no, perché prima si vedeva solo quello dentro. Però io lo vedevo.
Thank you. Today, I would like, next one, please. Today, I would like to consider some psychological and social aspects related to obesity in children and what can be done to improve the present situation and to prevent it. Obesity deteriorates the body image. It causes both depression and eating disorders. Therefore, self-esteem declines. Stigma also prevents the chance for these patients to seek medical services and to adhere to treatment. Next, please. We have to recognize the complex etiology of obesity, including genetic and socioeconomic factors, environmental contributors, community assets, family and cultural traditions, and individual choices. Next. weight stigma is prevalent and it negatively affects the health and success of patients in their daily life, not only in their personal, family, and social life, but also in education. Many examples throughout the history of public health demonstrate that the stigma due to a disease is a barrier for prevention, early diagnosis, and treatment. And we experience it in liver diseases. Next. Childhood obesity affects physical and psychological development. Some health effects and consequences of weight stigma are emotional and psychological, social isolation and academic worst outcomes, unhealthy eating behaviors, and worsening obesity. Next. The basis for the overweight young person, I think, are family and friends, especially parents, a school, and also the health care system. Next. I like to say something about the language. Be careful with the language. Addressing the stigma created by inappropriate use of language needs education. Words can help or harm. Moreover, we should be aware of body language. For that reason, eliminate the term obese children, which is usual in the media and the health settings. Instead, we should say children with obesity. Next. Adolescents and overweight and obesity prefer neutral words like weight or body mass index, whereas terms like obese, extremely obese, fat, or weight problem that induce sadness, embarrassment, and shame, and might increase the stigma and deteriorate their self-esteem. Next. Nowadays, social networks contribute to stigmatize obesity in children and adolescents. They might be cruel and sometimes anonymous. Next. Pediatricians, patients' liver associations, and youth-targeted media have a specific role advocating against weight stigma in children. Next. As a conclusion, parents are decisive to manage weight stigma in schools, in communities, and in their homes. Communication is crucial. Pediatricians can encourage parents to actively inquire with their children's teachers to ensure that plans are in place to address weight-based victimization in their institutions. Be alert. Friends and family members can be the source of the potential weight stigma at home. Schools, the healthcare system, and social media are vital. Additional stigma might be attributable to ethnicity, socioeconomics, and gender. Next, thank you for your attention. These are very important psychological, quality of life, etc. consideration for this population. Thank you very much. Now I have to introduce my friend Yanula Kola, who is the president of Cyprus Liver Patients Association and leader of ELPA NAFLD NASH group from Cyprus. And she will present results of ELPA NAFLD NASH survey. Thank you, Janula.
Thank you. Let me share my presentation.
Should I share, Janula?
No, no.
Okay.
No, thank you. Okay. All right. First of all, I would like, on behalf of ELPA NASH team, we would like to welcome you all. Say thank you to each and everyone for your response to our call to action. This shows, besides the recognition of the problem, and your commitment and dedication to do something about it. At this point, please let me introduce you the members of the ELPA NASH team, which we will start from Lona McAuliffe. She's from Denmark. Cindy Weinbaum from Israel. Manuel Baez Perez from Spain. Taja Teto Taket from Finland. Veronika Vetsikova from Slovenia. Of course, our scientific committee director and coordinator, Teresa Kasanovas, and we wouldn't go anywhere without her tireless helper and supporter. At this point, I take the opportunity to say many thanks to Mr. Milan Miskovic, and of course to our president, Marco Correggian, for his support. I would like to present now the survey. It was the background, as all we know, non-alcoholic fatty liver disease, also known as metabolic dysfunction associated fatty liver disease. Is excessive fat built up in the liver without another clear cause, such as alcohol use. The aims of the survey, it was to evaluate the knowledge of the disease in the general population. The methods, it was a total of 357 people, adults, from 5 different countries. They were participating in this survey. An electronic multiple choice questionnaire translated into 5 different languages, Danish, Spanish, English, Hebrew, and Greek. It was a big effort, this one, to translate all these in different languages. And I would really thank you, the people behind this. The duration of this survey, it was 6 months. It started 15th of January and ended in 15th of July. We got the patient consent and explanation of how the data will be used with the letter. It was, as I said before, a multiple choice questionnaire with 8 questions, normal questions, usual questions, whether they know what it's the NAFLD disease is, or NASH disease is, whether they know the prevalence of both of the diseases, and who can have the NAF disease, the symptoms, what are the complications, and whether they know whether there are available treatment for these diseases. What we have, it was that it was 86% they vote that yes, they do know what is the disease, and 14 they said no, and 85% they said yes, we know what is the NASH disease, and 50 say no. And it's remarkable that they know about the disease, they have heard it. The second questions, that it was questionnaire number 3 and 4, it was how much do they estimate the prevalence of NAFLD and NASH? So we have 10% estimated on the 8%, 20 to 19, 30 to 54, and 40. So those who calculate prevalence at 20 and 30 together, their number rose to 72. It's extremely high number. So they know that there is a problem. They know that it's a disease that they can find it among them quite easily. The second, the questionnaire, which is number 5, who is more likely to develop NAFLD? The answers vary. It's children 4%, youth 0%, adults 33%, and the 63, they say all the above. What it surprised me is that they don't expect to find this disease and to adults, to youth, sorry. And it might be we need to see why they think this. The second one, the questionnaire 6 and 7, the other one, sorry, the symptoms and the complications. They said, they answered that no symptoms, they have the 46 responders, few symptoms 58%, and a lot of symptoms 4%. So they know the majority that the most of them, they do not have, let's say, symptoms. It's a silent disease. And the question number 8, the final question, it's whether they know whether there is any available treatment for NAFLD. And here we have that if they have in mind if there is the treatment for NAFLD, they said that the medication, there is 4%, 13, no, sorry, the medication, they said that there are medication 13%, the surgery 4%, the physical activity 67%, and the nutrition, they 92%. So they know that nutrition, it is some sort of a treatment for NAFLD. The key messages for this survey is that most are aware that there is a problem, and over time it becomes bigger. What they do not know is that the effects of the disease can be severe and sometimes fatal. The most of them, they have answer about cirrhosis. Then also although they know that the necessity of the proper nutrition and exercise, it seems that they do not know how to put them into practice in their lives. And it was the survey, the small survey that it was conducted in the 5 different countries. Thank you very much for your time. Also, I would like to, at this point, with gladness, I would like to welcome a member of the NAFLD and NASH team, Mr. Manuel Perez. Manuel, he's from the FNED, National Federation of Liver Patients and Transplant in Spain. Manuel, please.
Hello, Janula. Hello, everybody. Beatriz, do you? Okay. So I wanted to address a call to action after the survey Janula just presented. We have seen the outcome of the survey. We have seen some, I would say, worrying problems like most of the patients.
Just a second, Manuel, because the PowerPoint is in, I think, just a second. It's in the protected view. I think this is my problem, basically. Just a second. Share. Here you are. Perfect. Sorry. I just have to change the status of the.
Next, it was the next slide. Thank you. So after the results of our survey, we have seen that, as Janula said, most of the patients don't know the potential severe consequences that NASH has. They also don't know that it's a disease that can affect any age group, and they continue to associate the disease with cirrhotic patients. My conclusion, our conclusion after these results is that we are lacking of more and better awareness. But I think we have to be honest. I'm a journalist, and we are doing awareness. The patient organization, ELPA, at national level, European level, also global level. But I think it's not enough. We have a limited impact as patients organization. So first of all, we have to establish alliances with mass media so we can amplify our message, we can amplify our awareness, and so we reach the majority of the society. Next slide, please. So I think it was Nikki before, she explained some programs some of my colleagues are going to implement next year. We need to act now, and we need to start with children, with awareness raising and prevention programs at school. So as I said before, colleagues from Cyprus, Denmark, and Spain, Lone, Janula, and Teresa, are going to implement next year the program called The Sooner the Better. The aim of this program is to achieve, let's say, pyramid education, to get from the children to the parents, to achieve a domino effect from the bottom to the top. Next slide, please. We already have support of many organizations. Some of them were here today with us, EPF, EASO, ESPAGAN, ECPO, but next slide, please. We need more. NAFLD, as I think Nuria said before, is a condition that affects now up to 25% of the population in Europe, even more if we talk about America. It's a disease which has very severe conditions, and we see not enough political action to stop the rise of this condition. We always talk about lifestyle. We have to change our lifestyle, our nutrition, and it seems to be a question of will. But as I think Nikki said before, we also have to talk about the socioeconomical aspects. Let's think about a person who works 8 hours a day in front of his computer. He earns 1,000 euros, and then he has to drive 1 hour back home where he has 3 children waiting for him. Will he buy healthy food and prepare elaborated meals, or will he just feed his children with the cheapest he finds and the fastest he finds? Will he bring his children to sport activities he cannot afford? Will he go running himself, or will he stay at home and rest in front of the TV after a long journey? I think if we want to change lifestyle, we have to change our society model. And that's only possible if we work together, but if we have political involvement and we change society, changing our policies. Next slide, please. Finally, I wanted to present you the leaflet ELPA prepared, well, our NASH group prepared, and I wanted to announce you that we officially opened the process to collecting logos and the endorsement of our message. So please join us. We need to work together. We need to be louder. It's the only way that society listens to us. Thank you very much.
Yes, you are absolutely right, Manuel. We need to work all together. It's a huge problem we have in front of us. It's becoming pandemic, the disease, and we need the contribution and the support and the help from each organization to go on. Now at this point,
sorry, Janula.
Yes.
I would like to say something, because I think it is worthy to say that we have learned a lot today. We have done a further step, and we have to continue in our efforts, such as political involvement. This is important, but also recognizing the efforts with this survey, because this is a multicultural and multilingual project. And I think in Europe, we are lacking of this, taking into account these differences. Thank you.
Thank you very much, Teresa. You are absolutely right. And now at this point, I would like to welcome the digital tools we will show to you that we use to educate children. It's animation, and it's offered from HERTZ, the Israeli Association for the Health of the Liver, from Israel. Thank you very much.
My name is Professor Amanda, a great scientist, renowned adventurer, and professional scholar of Mother Nature. Join me on an exciting tour to investigate the human body's largest internal organ, the liver. Let's take a closer look. The liver is located in the abdominal cavity in its right upper quadrant. It weighs about 1.5 kilograms. It consists of 2 lobes, and it's wonderfully able to regrow itself if damaged or transplanted. The liver has many important roles. Among other things, it is responsible for the metabolism of fats, proteins, and carbohydrates in the body. Isn't it nice? In fact, it is so important that without the liver, we cannot survive for more than 1 day. To demonstrate, I've invited 2 of my associates, Jiminy Jim and Lazy Larry. As long as we maintain a healthy lifestyle, a balanced diet, and exercise regularly, our liver will function very well and remain happy, as you can see with Jiminy Jim. What a beautiful liver. The problems begin when we load the liver with more and more work, by eating large amounts of foods that are rich in sugar, fat, and salt. This sort of imbalanced diet and lack of physical activity will simply cause our liver to collapse under the burden, like what happened to Lazy Larry. Under these conditions, a condition called fatty liver may develop, which increases the risk of deteriorated liver function and could even result in the need for a liver transplant. The most common liver disease today is fatty liver. In fact, about 30% of the population suffers from it. However, maintaining a healthy lifestyle, which includes daily exercise and a balanced diet, allows our liver to remain healthy and function effectively. healthy diet includes vegetables, fruits, legumes, whole grains, and foods high in fat from plants, such as tahini, avocado, olive oil, and nuts. Along with that, it is strongly recommended to reduce the consumption of sugars, high-fat pastries, and processed meats. You should consider diversifying your physical activity. Doing so will help you achieve different types of training and enjoy it a lot more. Take the dog for a walk, ride a bike, or work in the garden. Play games like hide and seek, or sports like tennis, soccer, and basketball. Go swimming, or running, or dance. Much to our delight, making sure to exercise and maintain a balanced diet now will save a lot of trouble in the future and can even restore a fatty liver to its healthy state. So remember, with exercise and balanced nutrition, keeping the liver happy is easy.
I would like to say that we have received too many questions, but due to the fact that we have far exceeded our time, we will skip it for now. But I would like to assure you that all will be answered. Thank you. And now I would like to call Mr. Marco Correggiano, our president, so he will have any closing remarks.
Thank you very much, Janula, and thank you all for sticking with us a little bit more longer. I need to say that every time that ELPA team prepares something, I prepare also myself, and I think that everything was already said, but I was so wrong. So there were so many things I should address, I need to address, so many presentations. Thank you, Manuel. Thank you, Emer. Thank you, Vicky. So many things. Thank you, Wolkan. So many things that should not be forgotten. So we will save this and have this and see this as a first step. So we will use as many information as we can from this event to push on political will to change something on a broader scale. We will also follow the advice of Manuel and try to influence mass media to spread the message. I really like the notion from Vicky, who said we need to broaden the message, we need to broaden the audience, because it's true. Sometimes on the meetings, we can see that the meetings are for people who are already informed about the issues, and we need to broaden than that perspective. And of course, I would like to say also thank you to Nuria, because I was not aware that multidisciplinary team can be involved also with the patient. So when we were thinking about a multidisciplinary team, we were thinking about medical professionals and never about inclusion of a separate patient. So maybe this is something that we can follow. Of course, we will try to influence, no, we will not try, we will influence media, we will influence the decision makers on the political floor, and we are already together working with medical researchers. So I don't know, Veronica, if you can show just one slide. So at the moment, European Liver Patient Association is involved in 10 medical research projects. One that was not accepted by European Commission was the one who was produced by Professor Romero. And the idea there was so simple, so brilliant, but in the scope of other projects, it was just not supported by European Commission. But it was just a notion to offer a fresh bottle of water in every restaurant in Europe. And I think when we move forward, we need such projects. We need to work together as patients, together with medical researchers, to develop also simple and easy to use solutions that we can use to stop this, as Janula has said, domino effect. So with that, thank you, Veronica. With that, I would just like to thank you all for your attention. We will be here. Don't remember about our call to action. We will remember to send you an update every few weeks. If you think that you can support the actions about the knowledge about the fatty liver, I do hope that you will reach out to us and we will do this together. So for now, thank you very much to all the speakers. Thank you all very much to ELPA members team of NAFLD and NASH group. So thank you for your attention.
Thank you.